Sexually transmitted infections, major public health issue, as we all know, in both resource-rich and resource-limited countries. The problem with sexually transmitted disease infections are that they are frequently asymptomatic, and they can also lead to various complications in patients if we actually don't actively ask about them. So some of the complications that you can see with sexually transmitted diseases that are infections that are not treated is upper genital tract infections, infertility, chronic pelvic pain, cervical cancer, chronic infections with hepatitis viruses, and HIV. So the approach to sexually transmitted diseases and management is then based upon disease or symptom-specific syndromes, and that can include your vaginal discharges, urethral discharge, ulcerative genital disease, non-ulcerative genital disease, and pelvic pain. Many patients have asymptomatic disease, and this will then obviously increase the risk of not only complications but also transmitting in public. Because I mean, a lot of times, if we don't ask about them because there's such a stigma attached to it, we actually never get to the diagnosis of it, and we never treat the patients, and they don't always have symptoms. And that is why screening is actually a very important approach with regards to sexually transmitted infections. So we've also now moved away from calling it sexually transmitted diseases to actually what is referred to as sexually transmitted infections, and that's specifically for that reason alone, that it encompasses the term with patients that are asymptomatic but have the infections. So what's now being the standard of calling it is actually sexually transmitted infections instead of sexually transmitted diseases. So the spread of sexually transmitted diseases, they generally spread by close sexual contact, sexual intercourse, and they can spread to multiple areas. And they can obviously be spread by contact with an infected partner's skin, genitals, body fluids, mucous membranes, such as the eyes, and mouth, etc. Some of the most common sexually transmitted infections that we have is chlamydia, genital herpes, genital warts, gonorrhea, hepatitis B and C, HIV and AIDS, syphilis, pubic lice, and scabies. Some of them which are bacterial, others which are viral, and some of them which are obviously parasitic. So it's important to actually be able to pick this up, because you want to pick up your bacterial infections quickly and treat them. So bacterial, parasitic, or viral STIs, and so if you have a bacterial present, you need to treat them with antimicrobials, antibiotics. If a viral STI is present, it is possible to remain asymptomatic for that period. And the problem with that is that if you're asymptomatic in that period, you can easily transmit it to your partners and other people around you that you're not even aware that you're actually spreading it. So So the risk factors and risk groups, we know that everyone that is actually sexually active is at a risk of getting sexually transmitted infection. But screening for sexually transmitted patients is obviously not practical, especially in our setting, because we have such a high burden of disease. But screening for the STIs then focuses on those who are at the highest risk of getting sexually transmitted infections. And for some STIs, this is done by target-specific risk groups that you can screen. For example, your females that are less than 25 years old, or men who have sex with men, HIV-positive patients, immunocompromised patients, and individuals entering into correctional services. In other cases, screening is obviously dependent on the assessment of the individual person's risk behavior. So, some people have higher tendency for changing partners and stuff, or behavioral factors on the prevalence of infection in the local community as well. So that's when you actually do the screening for specific groups. Okay. So this table that I've adopted from UpToDate, as you can see the reference at the bottom, looks at different patients. And I don't know if you can see it clearly, but I mean, these are different patients that you look at you group them into, so your variable line over here shows you the gender and the population and what is the routine screening that you want to do for these patients. And obviously we are not always able to do this type of screening for patients, but I think it's important if you have people coming in in specific groups, then you ask them questions that are related to, for example, in women that are less than 25 years old, you want to know about chlamydia and gonorrhea and HIV. And in our setting, obviously, we want to test HIV on almost every patient that comes in. So if you look at women, it's age less than 25, or women that are more than 25 years old, pregnant women, those with HIV, and those with, so women that have different sexual orientations, such as women that have sex with women, or women that have sex with women and men. And then men as well, they have different, you have different categories where you test men that are HIV infected, those that are not HIV infected, and those that have different sexual orientations but are HIV infected, and sexual orientations that are not HIV infected. And then there's the transgenders and gender diverse populations that you look at. So if you review this table, you can actually look at the factors that would affect these populations more dramatically. But I think generally just asking good sexual history and getting and actually making the point of asking for a sexual history is just important for patients. So in terms of sexual history, and this is, I think, where most of the bigger problem lies, because there's such a huge stigma attached to the fact that, you know, somebody could actually have a sexually transmitted disease. And often we don't ask the questions and the patients don't tell us. But I think if we actually start asking the questions, we do get a lot out of this, the patients. So it should be straightforward and not non-judgmental, with appropriate counseling regarding risk-taking behaviors as necessary. And then there's the 5 Ps of sexual history, which will follow in the following table, and we'll just go through them. And asking those questions can actually give you quite a overall view of, how to treat this patient. So the 5 P being your partner's practices, protection from STIs, previous history of STIs, and then pregnancy intention. So if you just go through those questions, it's pretty straightforward. And I think it also risk stratifies patients. Then you'd get a better idea of practices in terms of sexual orientation for patients, if they're using any type of protection, if they've previously been treated with STIs. And then obviously there's the whole pregnancy intention, whether there's pregnancy prevention, if they want to have children, or termination of pregnancies, and whether they've discussed it with each other. So the management of sexually transmitted diseases then obviously depends on the specific infection. So diagnosis of non-viral STIs generally should be done promptly, because you want to treat these patients quickly before the complications develop. So you don't want that lag between screening and treatment. And so the treatment of these sexually transmitted, so this is all taken from the South African guidelines, and it's very algorithmic. And I think if you have a resource available on your phones or little books, or like I think protocols in the ED and stuff, it becomes pretty simple to actually, just follow them as they're given. So patient complains of abnormal vaginal discharge and is not sexually active within 3 months. You look for symptoms. In patients. If they are not symptomatic, you treat them for bacterial vaginosis. If they do have any side of clinical symptoms, you treat them for bacterial candidiasis. Then you obviously do further examination on patients if there's cervical motion tenderness. If there's not cervical motion tenderness, if there is cervical motion tenderness, you treat the patient for lower abdominal pain. And there's an algorithm. We'll go to that algorithm later on. If there is there's no cervical motion tenderness present in a patient, then you will obviously treat them for cervicitis, and the treatment for cervicitis is then mentioned here as ceftriaxone and azithromycin. So it's stat doses, it's done in the casualty. And if the patient doesn't have any cervicitis, then you will continue the treatment for bacterial vaginosis, which is metronidazole, oral 400 milligrams, 12 hourly for 7 days. Now, obviously, I don't know if we follow up patients, but a lot of times patients can actually be lost to follow up. But if they do follow up, you want to see that they have response in 7 days. And whether if they don't, then you want to obviously refer them for further management. So for women that are sexually active and they complain of abnormal vaginal discharge and they have been sexually active within the last 3 months, you want to ask about lower abdominal pain or your cervical motion tenderness. If it is present, you will then obviously use the lower abdominal pain algorithm. If it is not present, then you will treat all cases, including pregnant women, with ceftriaxone, azithromycin, metronidazole. And if there is any signs of like a vulva that is scratched, inflamed, or curd-like discharge, you treat for vaginal candidiasis with your clotrimazole and clotrimazole or clotrimazole vaginal cream. And then if you also obviously want to ask the patients to return if the symptoms present, and if they are present, then you treat them with metronidazole again. So we said if there is lower abdominal pain present, then you're going to treat them for the lower abdominal pain. So here, it's important to ask the patient about their sexual activity and if they have vaginal discharge. Now, history taking is obviously very important here. And then you want the gynecological history, and you want to do a proper examination, especially like focus on the abdomen and the vagina. And then obviously we have emphasis on HIV testing here. So if the patient has any of the following, which says your pregnancy or missed period, recent delivery or termination of pregnancy or miscarriages, and often patient will, if they've had a termination of pregnancy in some outdoor clinic, in a backdoor clinic or something, they're never going to tell this. So I think it becomes important to then, gradually draw that history out of the patient of whether they've actually had a termination of pregnancy. Abdominal guarding, if you're doing a focused abdominal exam, or rebound tenderness, if there's any abnormal vaginal bleeding, any abnormal masses, or if the patient is actually pyrexial. Any of those are present, you want to refer these patients, and they're severely ill. If these patients are severely ill, you need to resuscitate these patients. And so the treatment is obviously ceftriaxone. You give IV 1 gram and metronidazole. So if none of those are present in a patient and they're still complaining of lower abdominal pain, so if they, and this is now if they do not have vaginal discharge or they do have vaginal discharge, regardless of what you do a urine analysis on the patients, and if you ask for symptoms of urinary tract infections, and that also goes back to taking a proper history. And then if there's no cervical motion tenderness, you will treat the patients. If there isn't any of those present, ceftriaxone, azithromycin, metronidazole. And then obviously you want to see that the patient improves within 48 to 72 hours. If they're not, then to come back and get a gynecological referral. And if they are, if any of those symptoms are present, UTIs, any symptoms of UTIs are present, then you treat them as a UTI. And if there is improvement within 7 days, and like I said, I mean, this is probably where we lose most of our patients, then you can obviously discharge the patient. And if there's no improvement, then you need to refer the patients for further management. So we don't see a lot of males in our ED, but I mean, they do also get sexually transmitted diseases. And obviously, most of the time, I think it's women that seek help before men seek help, but then there must be an emphasis on partner tracing. So they complain of urethral discharge or dysuria. You take a history, including the sexual orientation and examination. And if there's no visible discharge, you ask the patients to milk the urethra. And obviously, once again, emphasis on HIV testing goes without saying. And if there is a discharge present, you treat them with ceftriaxone, azithromycin. And if the sexual partner has VSD, you add metronidazole for the patient as well. Should improve within 7 days. If it doesn't, then you want to suspect ceftriaxone treatment failure, and then you will refer the patients as ceftriaxone treatment failure within 7 days before the investigation and management. Scrotal swelling in males, you want to do a proper history again, examination, emphasis on HIV testing. When you're doing the examination, you want to look for scrotal swelling or pain is confirmed for these patients. If any of this is present, you want to look if there is, for example, a torsion of the testes, or there's a history of trauma or other non-tender swellings thought to be due to sexual activity. Any of those are present, you're going to refer them for a surgical opinion. If they are not present, you treat with ceftriaxone and azithromycin, review after 7 days. If they're improving, then you can complete the treatment and discharge the patients. Genital ulcer syndrome. These are often patients that complain of genital sores or with ulcers with or without pain. So these can actually present painlessly. So you want to take a proper history of the ulcers, and if they are present, you want to obviously also emphasize HIV testing again. Then here you want to ask if the patient has been sexually active within the last 3 months. If they have been, you want to treat them with doxycycline because we have that bubonic plague risk over here. And obviously if the patient is pregnant, you can't treat them with doxycycline. So you treat them with your benzathine benzyl penicillin. And if they are they're pregnant and the benzyl penicillin is not available, then you can put them on amoxil and probenecid. HIV patients, well, HIV is unknown, which shouldn't be the case in our setting because, I mean, we have rapid tests available for everyone. Then you can add acyclovir, acyclovir for patients. And pain relief is obviously if the patient is in a lot of pain, and often a lot of patients can have pains with these genital ulcers, then you want to give them pain relief. So you need to review the cases in 1 week, and if the ulcers have healed or they are clearly improving, you can discharge the patient to complete their treatment, and if not, then you need to send the patient for HIV testing. There's no improvement, you need to start the patient on azithromycin, and if there's still no improvement after 7 days, you need to refer these patients. Okay, so this is the bubonic plague. I don't know how important that is in our setting. I actually didn't manage to read up the stats if we have any of this present currently in South Africa. But if they complain of a hot, tender inguinal swelling with surrounding erythema and or edema, you want to take a proper history. If you confirm it, you want to treat them with azithromycin. And if it is fluctuant, you want to aspirate the pus. So I just want to quickly move to syphilis because that's quite important in our setting, and the time apparently on the Zoom is running out. Okay, so syphilis. You want to do a syphilis test for all patients that are sexually assaulted, or if you have secondary syphilis. So secondary and tertiary syphilis obviously present very differently. Here you're going to have like multi-system disease. In tertiary syphilis, you have neurosyphilis.
Hi. Fatima, I'm going to say it's okay. If the Zoom runs out, we all just log out and log back in again. So you don't have to rush faster. It's okay. We started late, so don't worry about that. So you don't have to speak faster than you were. Don't feel the pressure. If it finishes, then we just all log off and log back in again. Okay. It's not to worry.
All right. Okay, thank you.
So you can go at your pace. Don't stress. That's all I'm saying. Don't feel the pressure.
All right. Thank you. Okay, so coming to syphilis, so you want to do the RPR test is indicated in all sexual assault cases, of course, and then secondary syphilis and tertiary syphilis. Now, the important thing over here is that you actually need to know how the secondary and the tertiary syphilis will present, and a lot of these patients will present with multi-system disease, and in secondary syphilis, they can actually also present with lesions that look like warts. So you need to just you need to know what you're looking for. And then tertiary syphilis will obviously present with cardiac lesions and neurosyphilis and stuff like that. So so you do an RPR on patients, and then if you have a negative results, if you just finish the negative result part over here, you can you will rule out secondary and most tertiary syphilis because and then you will repeat the RPR in 3 months only in sexually assaulted cases. And if it is negative, obviously this indicates that there's cure in previously treated syphilis cases. And if tertiary syphilis is suspected, which is obviously neurological, cardiovascular, as we mentioned before, and the RPR is negative, you need to then refer the patient to a tertiary hospital for further investigation. Because I think often people forget that syphilis is actually a vasculitis if you read the histopathology of it. So your RPR result is positive. You've had previous RPR and the results are available and previously treated. So you've done a previous RPR and you have a result, and that result was positive and it was previously treated for syphilis as well. Then you're going to look at what was the last RPR result. If you look at the last RPR result, and if the current RPR is more than 4 times the last RPR, that is, for example, if it was the titers are 1:8 and now it is 1:32, then you are going to say that 1:32, this is a negative, and you've tested negative for RPR in the last 2 years, then if you've tested negative for RPR in the last 2 years, and if the answer is yes to that, then you just treat the patient with your benzathine benzyl penicillin. And if the patient has, and if your RPR result has not been negative in the last 2 years, then you treat as latent syphilis, which is also your benzathine benzyl penicillin. Now, if your current RPI is 4 times lower or is unknown, or is a known serofast patient, and it's still the same, or there's a lower or no more than 2-fold higher than the last RPR. So, for example, if the patient has the titers are 1:4, and now the patient results and is no more than 1:8, then you can actually discharge that patient. Obviously, the other thing that we also want to be careful over here, and there's these little caveat boxes right next to the algorithms, and these are, obviously it looks at syphilis treatment and latent or late latent syphilis, and then a big thing that if you go back to the slides and you look at them, is penicillin allergies and other allergies to medication. And I think we shouldn't overlook that. So always just ask the patient if they've reacted to any medication that they've taken before. So I think these algorithmic treatments are pretty straightforward, and they're all present. So I think it's sort of like we shouldn't have an excuse not to be able to treat these patients. There shouldn't be an excuse to say that, oh, I didn't know, because I mean, I think that doesn't stand in the court of law anymore. So this is the medical treatment of the patients, and again, very algorithmic. Early syphilis treatment, check if the patient if the patient was initially treated, how were they treated? If the patient has penicillin allergy, how do we treat those patients? And then if you have late or latent latent syphilis treatment, how do we treat? And mostly it's your benzathine, benzyl, penicillin. You just need to know how what the different doses are for the different presentations, and you don't have to memorize these doses, because all of these guidelines are actually available at your fingertips, and you can just log onto your phone, look up the guideline, and just confirm your doses. Even if you think you know it at the back of your head, often we confuse doses between medication. Just go back, look at the algorithm, follow it, and treat the patient. And then obviously right at the end here, tertiary syphilis, neurosyphilis, cardiovascular syphilis, you need to refer these patients. The other problem, and that what we'll see very often here at Rahima, is patients that are pregnant and they might have a positive RPR test. So all these patients, all pregnant women in the first antenatal visit and repeated testing at 32 weeks. And I don't know how many of us actually do a 32-week repeated test for women. You want to test these women, and obviously you also want to check for HIV at the same time. Want to take a history and examine, and you need to explain the need to take a syphilis screening on this patient. And then for HIV counseling, if you want to check for HIV, you want to obviously pre-counsel them. And then when you are taking bloods, you want to do an RPR test always, and it says here always, and you need to explain to them why you are doing it. And then HIV, obviously they've consented to do the HIV test, and you do the HIV test on the patient. So if they have any STI syndromes or illnesses that are present, you're going to follow the appropriate flow chart. You're going to go back, follow that algorithm, treat the patient appropriately. If the patient has a positive syphilis test, this is you need to treat the pregnant woman with for the syphilis. And the reason for that is that because it's such an old disease, and penicillin is the treatment for syphilis, we would have thought that it's actually, we've overcome this disease. I mean, if we've managed to overcome things like polio, then why do we still have syphilis? But the thing is that nobody looks for it. And the other problem is that this is actually still a very big problem. And I don't know if anyone has had any experience in neonatal ICUs and 16B wards, but this is there's a lot of patients that you're treating for congenital syphilis. And some of them don't do very well, actually. So if the patient is pregnant and you want to treat them for the benzyl with the benzathine, benzyl, penicillin, and if they have an allergy, then obviously you want to treat them appropriately for with the allergy. So if the patient is if you've tested the patient for HIV, then obviously you're going to do the counseling and then start the HIV treatment on the patient, and then obviously you need to tell the mother about compliance and do a proper counseling for the patient so that they can take their medication. And I think if we do proper counseling in terms of why the testing is important and why the medication is important, we have less people that come back with non-compliant medication or treatment failure because of non-compliance. So if, for example, we took, the mother was missed and there wasn't any, she didn't take any medication for her syphilis and her syphilis test is positive, you want to treat asymptomatic babies and you want to treat symptomatic babies. In your symptomatic moms and your symptomatic newborns of mothers with positive syphilis test during pregnancy, you want to refer them because they can present very, they have so many problems, and it's like every system is involved. They have skin lesions, they have peeling skin on the hands and the feet, they have bone marrow depression, they have everything. And then your asymptomatic babies, you still want to treat them even if the mother, when the mother tests positive and the mother was not treated, or if the mother received less than 3 doses, or if the mother delivered before she completed her treatment. So all these things are very rare. All right, so see if we finish the previous slide. All right, so so this table just basically takes you through if patients present with more than one STI at the same time. So they have multiple complaints at the same time. So if you look at it, once again, very algorithmic, very straightforward. So if you review the table, it should take you through, it should give you a good guideline on how to treat these conditions. So your genital molluscum, it's the viral infections that can be transmitted sexually and non-sexually. They're usually self-limiting, except in immunocompromised patients, of course. And they are, so these genital warts are usually your papules, and they look like, they have little stems, and then they have like a growth on top of that stem. And they have the central dent as well. So the treatment for that is your tincture of your iodine, where you want to apply to the core of the lesion, and that usually helps them just fall off. And they can be self-limiting, but I mean, it takes a long time. So if the patient comes in, they're obviously, I mean, besides being aesthetically not so pleasant, it can be pretty uncomfortable as well. So genital warts, and
before you go on to the next one, sorry to interrupt, can you just let the other people into the meeting?
Oh,
I think there's a few people who are trying to rejoin.
Okay, sure. Apologies. I think that's everyone I've invited. Is anyone waiting?
Thank you.
So just cancel that. So with the warts, these can occur in your anogenital area, and I just want to emphasize that because we actually never open up the anus to look what's going on between that, and we miss a lot of things such as piles, or even your some skin lesions, or even in patients that are uncontrolled diabetics, you see your acanthosis nigra is actually sitting between the anal folds, and so it's actually important to just open up the area and see what's going on there. And I mean, the vagina, the cervix, the meatus, or the urethra can occur basically anywhere. They can be hard as soft, and they also resolve within 2 years if the patient is not immunocompromised. So they do not look typical or fleshy. They can be fleshy or wet. You want to perform a syphilis test in these patients because you want to rule out secondary syphilis, and as we mentioned previously, because secondary syphilis can actually present like this. And HIV testing, as we said, goes without saying. So you're going to refer all patients that have warts of more than 10 millimeters, inaccessible warts, for example, they're inside the vagina. You do a speculum exam and you actually see them inside the vagina or the cervical warts, then you want to refer them. And obviously if there are just too many, that you can't actually differentiate any of them. So that's when you want to refer these patients. So pubic lice can happen a lot of times in especially children. And if it does happen in children, you need to exclude sexual abuse in these children. So you'll see them in confined to pubic, once again, pubic and perianal areas, and they can sometimes occur in the eyelashes. And I think if it's in the eyelashes, often people would seek help a lot quicker than they would if they're in more confined areas. They can cause a lot of itching, so patients scratch and scratch and scratch. And I don't know if you guys have seen everyone's nails these days, but I mean, they scratch so much that they can actually erode the skin. And with that, you can get a superimposed bacterial infection on top of that, you know. So general measures, personal hygiene, of course, you know, you want to thoroughly wash clothes, bed linen, and have them decontaminated. So you want to tell the patient to actually wash it 2 days prior to the start of treatment in hot water, and then iron the clothes. The treatment of benzoate, 25%, you want to apply to affected areas. If you have anything,
I'll take the volume down on this one.
If you have anything in the eyelashes.
Hi guys, please unmute yourself. Sorry, it's throwing Fatima off.
So if it is present in the eyelashes, you want to apply yellow petroleum jelly. And you don't want to use the white one. Don't want to especially use that near the areas, because it actually has a very high content of erosive substances in it. And you don't want to obviously apply it into or around the areas. And you'll be surprised how patients actually don't know these things. So you just need to tell them this when you're telling them how to take care of it. And like I said, the children that come with this pubic lice, you want to exclude sexual abuse in these children. Yeah, so there was one slide that we skipped. I think it might have been, was it this one?
Fatima, there was one case that I think you're going back to. Yes, there we go. I think it was the male no, it was the balanitis, wasn't it?
I think it was
balanitis.
Yeah, the balanitis. Yes, it is. So these are patients that can complain, and like I mentioned earlier, men are often not. They don't seek help as quick as women do, but and when they do, then it's usually a big problem. So the patients will obviously complain of soreness or itchiness of the glands, and then there's the inability to retract the foreskin. And obviously they can have like a bad smelling, like a foul smelling discharge or whatever it is. And obviously you also just want to look that the patient doesn't, you will take a thorough history once again. HIV testing, and you look at the foreskin if it cannot be retracted, if there's a tight phimosis or something. If you can retract the foreskin, you want to clean it out nicely. You want to re-examine after you've done the cleaning, and then you examine the glands. And if it is inflamed, if it is non-inflamed and there's no other signs, example ulcers, then you want to just treat the patient as per an STI algorithm. If any of those, if the glands is inflamed, then you want to tell the person, obviously, of personal hygiene with retracting the skin and washing the area, and wash daily with water. Also want to avoid any irritants like soaps and other fragranced things that people use in the bath these days. And then you want to give them the clotrimazole cream to apply for every 12 hours for 7 days. And you want to do a glucose urea on these patients. If the perform an analysis of the glucose urea, if the patient has glucose in the urine, you want them to return after 7 days. And men obviously usually tend to have poor adherence to medication and other treatments than women. So if they come back and they're still symptomatic, then you want to obviously rule out that they haven't had poor adherence. And if they are poorly adhering, you want to retreat them with the same treatment with the cream for 12 hourly for 7 days. And if they're not, then you want to obviously treat them as refer them as treatment failure. And then for these patients, we can obviously also refer them to to urology for circumcision. So I think in conclusion, what's really important is to realize that this is not something that's uncommon. And the only reason why it's probably referred to as uncommon is because we don't ask for it. And if we don't ask for it, the patient's not going to tell us. And if the patient doesn't tell us, we're never going to know. So it's just important to include history, like sexually transmitted infections history to patients. And if you do it as we described in the table previously, I think you can get a lot of information out of the patient. And the thing is that these are treatable causes. So find them, treat them, helps the patient. That's our primary job, you know. So yeah, thank you. If there's any questions, I hope I can answer them, and I hope everyone benefited from the presentation.
Thank you very much, Fatima. I don't have any questions. I just want to say thank you for presenting. I know we all feel awkward when we have to do presentations. Public speaking is never nice. You did really well. And even though it feels like a not nice topic, it's a really important one considering where we work.